spiral shape. Their tightly coiled form is not just for show, it plays a big role in how they move and interact with their environment. Understanding this shape helps us grasp how they behave and why they're important in medical science. Spirochetes are large, spiral-shaped bacteria known for their corkscrew movement, which is driven by special structures called endoflagella located inside their outer membrane. They are gram-negative, which means their cell wall has a specific structure affecting how they respond to antibiotics. This corkscrew motility allows them to move efficiently through viscous environments like mucus or tissue. Now, comparing spirochete families, we see two main groups, Spirochetaceae and Leptospiraceae. Spirochetaceae can survive without oxygen or with little oxygen, and they don't have hooked ends. This family includes genera like Treponema and Borrelia. On the other hand, Leptospiraceae are obligate aerobes, meaning they require oxygen, and they have a hooked morphology. This distinction helps us understand their habitats and pathogenic potential. When it comes to pathology, Treponema pallidum, the syphilis-causing spirochete, enters the body primarily through tiny breaks in the skin or mucous membranes during sexual contact. It can also cross the placenta from mother to fetus. Once inside, it travels through the lymphatic system to nearby lymph nodes and then spreads widely through the bloodstream, which explains its systemic effects. Focusing on Treponema pallidum, it's the exclusive cause of syphilis, a sexually transmitted disease affecting humans only. The infection progresses through 3 clinical stages: primary, secondary, and tertiary. Each stage has distinct features, and understanding these helps in diagnosis and treatment planning. Primary syphilis begins with a small bump or papule, usually on the genitals. This bump produces thick fluid rich in spirochetes, which then develops into a hard sore called a chancre. Nearby lymph nodes become involved as the body responds. Interestingly, this chancre heals on its own within about 10 to 40 days, leaving a scar behind. Recognizing these stages is crucial for early detection. After the primary lesion heals, there's a symptom-free period lasting a few months. Then the bacteria multiply and spread through the bloodstream, causing symptoms like flu-like illness and swollen lymph nodes. A characteristic rash appears on the skin and mucous membranes, and complications can affect bones, eyes, and the meninges. These secondary symptoms often resolve spontaneously over several years, but the infection remains. Tertiary syphilis is more complicated. At first, there may be no obvious symptoms, making diagnosis tricky without specific serological tests. This stage can involve serious cardiovascular problems like aneurysms, and lesions called gumas may form on organs. Neurosyphilis can develop, leading to nerve degeneration. These late manifestations highlight the importance of early diagnosis and treatment. Congenital syphilis occurs when the infection passes from mother to baby through the placenta, usually after the 4th month of pregnancy. Without treatment before this time, lesions can develop in the fetus, potentially causing miscarriage or stillbirth. There's also a mention of non-sexual acquisition, such as iatrogenic transmission, indicating other routes of infection to consider. The immune response in syphilis is a double-edged sword. Tissue damage and lesions are mainly caused by the body's immune reaction rather than direct bacterial action. Despite a strong immune response, the bacteria can persist for decades, evading full eradication. Early in infection, the immune system's cell-mediated response is even suppressed, allowing the pathogen to establish itself. Besides Treponema pallidum, other spirochetes cause important diseases. Treponema denticola and vincenti are linked to oral infections like ulcerative gingivostomatitis. Borrelia species cause Lyme disease and relapsing fever, while Leptospira interrogans leads to leptospirosis, also known as Weil's disease. Recognizing these different spirochetes helps in diagnosis and managing various infections. Diagnosing spirochete infections involves collecting specimens like thick genital discharge or blood for serology. Dark ground microscopy allows us to see their motility, and silver staining highlights their structure. Non-treponemal serological tests detect reagent antibodies using cardiolipin antigen, but these are nonspecific and not confirmatory, so their limitations must be carefully considered in diagnosis. For confirmation, treponemal tests are essential. These include specific assays like treponema pallidum agglutination, immobilization tests, fluorescent antibody tests, and hemagglutination assays. Treatment is straightforward, with penicillin and doxycycline being effective options. This combination of precise diagnosis and effective therapy makes managing syphilis quite achievable when caught early.